And critical care echocardiography is limited only for the intensive care unit, and the normal standard transthoracic echocardiography, which is very sophisticated and detailed. I would like to say something about the ultrasound assist physical examination. This is the ultrasonographic stethoscope. It allows to specify findings detected by the physical examination. It's often not recorded. These findings are documented in the progress note, where we describe the physical status of the patient. Now I'm mainly focusing on the cardiac point of care ultrasound or rapid cardiac assessment. Here we have a limited imaging protocol to detect the determined list of generally readily apparent pathophysiological findings, to rule out or to confirm the suspected diagnosis. It facilitates serial assessment, so we can repeat our examinations in several time, and it also allows immediate diagnosis. And it's very important that in the rapid cardiac assessment the recording of the imaging is very important. Now the cardiac point of care ultrasound is readily available than ever. The device there is a miniaturization in this sector. It provides a very good scan, very good picture, and we use two basic type of echocardiography. The first one is the 2D imaging. This is the mainstay of the echo imaging. It allows structure to be viewed moving in the real time in the black and white scan. And these small machines allowing for us also to use the Doppler technology, and it's allow for us to detect the blood flow. In the point of care ultrasound, we are not using the sophisticated methods like continuous in cardiac imaging, the continuous wave or pulsative wave Doppler, or tissue Doppler imaging, or three-dimensional echo. The focused cardiac ultrasound is using only these two type of methods. We have five views, five standardized views. These are standardized scans, but it's a restricted protocol. We have a parasternal long axis view, parasternal short axis view, apical four-chamber view, subcostal four-chamber view, and subcostal inferior vena cava view. The patient position is very important because mainly we use PoC-US in the emergency settings, that the patient's mainly lying on on the back, but the parasternal views are much better when the patient is in the steep left lateral position. If the image is still suboptimal, we can ask the patient to breathe in and hold their breath, and it will further improve many views. This is the parasternal long axis view. It's very important that the optimal cardiac view is different from patient to patient, since the ultrasound image is dependent on the relative orientation of the heart and lung in the chest wall. So this is the parasternal long axis view. If we are rotating the transducer 90 degree from the parasternal long axis view, we get the next one, standardized view, which is parasternal short axis view with the left ventricle and papillary muscles. The third one is the apical four-chamber view. It's obtained by placing the transducer frequently in the fourth or fifth intercostal space, and the orientation of the transducer is facing to the left shoulder. And this is the typical apical four-chamber view with the left ventricle, right left atrium, and in the right ventricle, right atrium. The fourth one is the subcostal view. the patients should lie supine. If the abdominal muscles are very tense, we should be ask the patient to bend their knees, and it will improve the patient the image quality. And also it's very important in the subcostal view, the inferior vena cava view, because if the inferior vena cava is very dilated, it suggests heart failure, right heart failure. And if this is so thin and with a large collapse during the inspiration, it suggests hypovolemia. The next thing is lung ultrasound, which we here in the previous presentation, and it's closely related to the cardiac ultrasound because heart failure is a very frequent condition, and the lung ultrasound will improve our diagnosis regarding the heart failure. If we put the transducer on the chest wall in the healthy patients, we can see a complete darkness, and in the textbooks we can also read that because ultrasound energy is rapidly dissipated by the air, ultrasound imaging is not useful for the evaluation of the pulmonary parenchyma. However, when the air content decreases in the lung due to the presence or accumulation of lung exudate, transudate, blood, collagen, the acoustic mismatch between the lung and the surrounding tissue will decrease, and consequently we will able to examine the lungs. Okay, and what happens here? This is the normal lung with in healthy patients. We put the transducer. There is a darkness. This is the pleural line. A pleural line here, and after this is a line. This is a reverberation of the pleura on your left side. And if the fluid content increases and air content decreases, it appears B lines. B lines is a comet-like artifacts fanning from the pleural line to the bottom of the picture, and it's the number of the B lines is related to the severity of congestion. How many scanning sites we need in the general practice to assess B lines? For the quick exam, 4 or 8 scanning sites is enough, and it takes only 1 or 2 minutes. Here is the typical sites for the scanning of the B lines. There is a posterior axillary line, anterior axillary line, and parasternal line, and we add some added lines in the level of the mamilla, and we will have these 4 scanning sites to detect and to count the B lines. And as I mentioned, the B lines increases along with the decreasing air content, and the B lines number is absolutely related to the severity of congestion. So it's already validated technique, so it's closely related to the left ventricular systolic function, to the left ventricular diastolic function, the severity of the diastolic dysfunction. It's closely related to the estimated pulmonary pressure or to the capillary wedge pressure measured by the right heart catheterization, and also it has a prognostic value. And now we are going back to focused cardiac ultrasound. In which circumstances we need point of care cardiac ultrasound? The first is the chest pain, and these are the most common symptoms in patient in general practice, or in the acute in the emergency settings, the circulatory failure or shock, respiratory compromise, cardiac arrest, chest or cardiac trauma, or syncope, presyncope. What is the actual diagnosis behind the specific signs? We can observe the ischemic left of right ventricular dysfunction. These are the signs of heart failure. We can also observe the complication after the myocardial infarction, the aneurysm formation. Cardiomyopathies, it needs more experience to recognize the typical signs of cardiomyopathies, like dilated cardiomyopathy or hypertrophic cardiomyopathy. Also, cardiac tamponade, it's or pericardial effusion. This is not a difficult diagnosis. Pulmonary embolism, hypovolemia, shock, and pleural effusion. What are the target of the examination? It's that the global left ventricular function and size is normal or not. The global right ventricular size is normal or it's impaired. The pericardial effusion to assess the tamponade physiology. The intravascular volume assessment, we can recognize also the growth signs of cardiac disease, or gross valvular abnormalities, large intracardiac masses. I will show you an example for these things. Training. First, we have a training program for the point of care cardiac ultrasound in comparison of the normal standard echocardiography. The learning curve for the focused cardiac ultrasound is relatively rapid, and the duration of the training is can be simplified. First, we have to determine the training requirements. Example, separate training is required for the different point of care cardiac ultrasound application. For example, if I'm working as a GP, I have to know the growth signs of heart failure and other simple things. But if I'm in the intensive care unit, I have to know the pathophysiology of the pericardial tamponade, or the complications of the acute myocardial infarction, or so on. The other thing is to assess first the experience category, because if I'm absolutely a novice users, I have to start with the basics. But if I have some experience with the cardiac ultrasound, like there are several universities already included the basics of the ultrasound in the curriculum, so the young GPs are or young doctors maybe are familiar with the basics of the ultrasound. We have to also to determine the objectives and time frame, and we have to elicit and correct the misconceptions. The first thing is during the training is the observation. The guidelines and the position papers emphasize that the echo lab is a starting point. First, we have shadowing the echo lab step and observing the process of the echocardiography. We have to learn the indications, because cardiac ultrasound is not good for the every disease and every conditions. We have to know also the limitations of the echocardiography, and we can also observe the acquisition images, the interpretation, the preparation of the reports, and to use and to learn the appropriate use criteria of echocardiography. The second one training step is the scanning, which is the most important thing. I think there is an essential. We have a different type of how to learn scanning. The first one is to observe the sonographer, or holding the hand scanning when the physician or the nurse is the sonographer is here for us to do the standardized views. We can do the extra views after the physician finished the examination, and the last one is the education of saved independently performed scans. And finally is the interpretation. It can be reading with the experts, reading independently with subsequent expert review. And there is a very important that it can be continuous. That repetition experience are crucial in scanning and also in the interpretation. What about the training time? If someone has some experience, 1 or 2 weeks is enough to spend in the echocardiography lab. But if there is no previous experience, there are novice users, I think it's to spend a month in the echocardiography is enough. There are also some misconceptions during the learning curve. This is the expectation that I am a master over the short time period, expectation that I have full competency during after the training, and the misconception regarding the utility of ultrasound in clinical settings where it would not be useful. It's typical that cardiac ultrasound is not able to detect, for example, coronary stenosis or coronary calcification. This is the most frequent problem. There are also, we can make an errors. It can be imaging exclusion. Here is one example. I cannot image the ascending aorta, where is the signs of aortic dissection, and this leads to the omission of aortic dissection. It can be interpretive omission, not recognizing the wall motion abnormalities. However, the assessment of wall motion abnormalities is not in the PoC-US application. We have a new guideline or position paper, and it's emphasized that the assessment of wall motion abnormalities is absolutely in the full echocardiography is for the cardiologist. Also, it can be misinterpretation, mistaking pleural fluid for and pericardial effusion. It can lead to unnecessary procedures and the risk of complication. There are some point of emphasis to know the limitation of the point of care ultrasound and the ultrasound device. The second one is very important, to know the users when to order the standard normal echocardiography, and scans must be placed always in the clinical context. There are also some legal issues and precautions, because we know that the diagnostic errors are likely to occur in the emergency settings, and we use point of care echocardiography mainly in the emergency settings. So should be fully aware of potential medical legal consequences. No clinician should employ any form of cardiac ultrasound beyond their competency, and training, assessment, and continuous quality improvement are crucial components for the point of care ultrasound. I will show you some typical pictures and scans. For example, here in your left side is a normal heart with the left ventricular function is normal, and the left ventricle is normal in size. However, in the next side is it's impaired ejection fraction and dilated right ventricle. Also, in the next panel, here is the normal heart, but there is impaired left ventricular systolic function with dilated right ventricle and apical aneurysm. There, the endocardial border is very thin. The next one is also here is a normal one, but there is a typical of heart failure with preserved ejection fraction. There is a left ventricular hypertrophy and dilated atria. Is a typical signs of heart failure with preserved ejection fraction. Here is next is the problem is in the right side. Here is the normal one, the healthy patient with a good right ventricular systolic function and normal right ventricular size. However, in the opposite side is the dilated right ventricle, impaired right ventricular systolic function. The patient with after the pulmonary embolisms is the chronic thromboembolic pulmonary hypertension. Also, pericardial effusion is a very simple diagnosis, and also pleural effusion can suggest heart failure. The assessment of the intravascular volume status is also the very important. Here is the inferior vena cava in patients suffering from heart failure. It's dilated and no collapse during the inspiration and expiration. And then the other side, there is a hypovolemia, where it's very thin and totally collapsing inferior vena cava. We can also recognize the growth signs of chronic cardiac disease if we put the transducer on the patient and there is an obvious sign of heart disease, like here the dilated cardiomyopathy, the dilated chambers, cardiac amyloidosis with a very thick septum and lateral wall, pulmonary hypertension, or hypertrophic cardiomyopathy. The point of care ultrasound is also able to recognize the gross valvular abnormalities. Here is the mitral insufficiency, and in the opposite side is the aortic stenosis with calcified aortic valve, and the opening is very restricted. Large intracardial masses we can also recognize. For example, here it's myocarditis and the apical thrombus formation. In the other side is a myocardial infarction with apical thrombus, and here is endocarditis in the artificial aortic valve. So this is something new, that if the patient is entering to our office or department and is complaining for dyspnea or heart failure, we can also observe other parameters, not only the, for example, the left ventricular function. Here, for example, here is the left ventricular function impaired, but also the inferior vena cava and the B lines. And if we put together these findings, our diagnosis will better, and we can make the diagnosis most easily. And finally, the reporting. The reporting is also very important. Some would argue that the extension of physical examination, if we put the transducer after the physical examination, we cannot write something about it. But if we perform focused cardiac ultrasound, the short formal report is very important. We have to notice that this is not an normal echocardiogram. This is a focused cardiac ultrasound. What was the indication of the study? What we find? And this is very important to note that no other cardiac structures were evaluated, and also the recording and the storage of the images is it's very important. In conclusion, we can say that echocardiography is an extremely powerful diagnostic tool. When used carefully by appropriate physicians and in appropriate clinical settings in the right patient, it can have a very powerful benefit for the patient. Yet the risk of the indiscriminate use must be decreased through the careful training and demonstration of continued practice. If training and these safety aspects are satisfactorily completed, echocardiography can be successfully and widely used in the primary care. Thank you very much for your attention.
So, hello everybody. I'm endocrinologist. Even though thyroid disease wasn't on any on the PoC-US presentation till now, and if we focus on symptom-induced screening, that I would like to remember you, around 5% of the general population has a palpable thyroid nodules, and less than 1% will have an acute onset thyroid deformation or cervical deformation, because thyroid is very, let's say, superficial. Somehow everybody is performing thyroid ultrasound, and I think making a little bit of what to do on PoC-US from the thyroid point of view, since almost everybody is using and performing thyroid ultrasound, is a good topic for today, and this is why I thank Dr. Jakob for his invitation, and I'm glad that this event is growing from year to year. So I have no disclosure as a speaker. What we should emphasize when we check for, let's say, some means thyroid. First, we have to take anatomy into account, and then to answer to the question, do I have a goiter or not? Is it nodular or it's a diffuse one? And actually, what are the implications from the clinical point of view, since around 50% of the population, adult population, has a thyroid nodule observed on ultrasound, and we cannot focus on more than 50% of the population. So from the anatomy point of view, we have to have integrity, position, so the right position of the thyroid, right lobe, left lobe, and isthmus, which are the common variants that we can observe when we're performing on daily basis. So first we have to think about agenesia, which actually means you are in the right place with your transducer and there is no thyroid tissue at all. And you're not mistaking, but it isn't. And of course, you don't have in front of you a total thyroidectomized patient, which you can see by the scars, or you can ask. And in front of such patient, from the clinical point of view, you have to answer, or you have to think about two things. Either it's a real agenesia, meaning the patient in front of you has a severe signs and symptoms of hypothyroidism, and if it's a agenesia, then you have a congenital creatinine case in front of you. And if is this the case, you re-emphasize by scintigraphy showing there is really no thyroid tissue in the structure in the entire body. Or if your patient in front of you has no signs and symptoms of hypothyroidism and he is not under any treatment, it means he has thyroid tissue somewhere but not in the right position, so he has an agenetic type. And then you have to re-emphasize the position of ectopic thyroid by scintigraphy. It's very common to have unilobular agenesia. I don't know if you see this. No. So you have it here. You have on the maybe I make like this. Do you see something? So here is the isthmus. Here. So you see the isthmus, like here, and you see the correct right lobe. There is no left lobe on the image. Transversal scan, longitudinal scan, re-emphasizing on scintigraphy that you have only one-sided lobe present. The same is valid for the right lobe agenesia. So on your left image there is no lobe, on your right image there's transverse scan of the left lobe with some small nodule inside, and re-emphasizing longitudinal scale this thing. What is common and can be seen is the so-called accessory lobe, which can be found between 12 to up to 70% of the general population, and it can be mistaken by a nodule. But I don't know why this is jumping. Sorry. It can be mistaken by a nodule here when you. This is a typical position. Ectopy, as I showed some images before, means no thyroid tissue in the normal position when you scan. You can go lucky, and if you scan from the conventional position up in the parachioidan thing, you can find in this situation image on your the other side. It's ovular sized image, which is very similar to thyroid tissue, but you can never have an ectopic diagnostic by ultrasound. You always have to re-emphasize your clinical suspicion by performing scintigraphy, which the typical diagnostic in re-emphasizes that what you saw is really thyroid tissue, but it can be seen. Move forward to diffuse goiter. Diffuse goiter means enlargement more than the conventional volume, which currently is considered to be around 20 milliliters in European population, counting together right and left lobe. And I did presume that everybody is really let's say, familiarized with how to make the evaluation of the thyroid volume. What is important from the clinical point of view? So to make a diagnostic, but actually what means diffuse goiter? I'm not interested in seeing a patient if he has a 22 millimeters volume, even if the European normative is 20 milliliters. Actually, is it a disease behind this volume or not? So just pushing in direction diagnostic diffuse goiter only because of 1 extra milliliter is not necessarily a good thing, because we will overdiagnose people. We have really to know, do we have a real diagnostic and a real thyroid disease behind this 1 or 2% increase in the volume? Do we need to monitor this case or not? Are there any treatment indication or not? So when we go and discuss about thyroid disease, diffuse thyroid disease, we should not focus not only on volume. So we have to check what we have to check first. We have to check echo pattern. And echo pattern doesn't mean to look how thyroid looks just comparing with the strap muscles, because they are always hypoechoic, and compared with the strap muscle, thyroid is almost always more echoic than that one, is actually to look to the submandibular salivary glands and to compare with that the echogenicity. So when you look, this is side-by-side image on the same side, you compare it with these glands, they are very easy to be found, and if the echogenicity is more than similar, then you can say isoechoic or normal echogenicity of the thyroid. Whenever in this situation, and this is right longitudinal scale, right and left lobe of the thyroid, comparing with the same side salivary submandibular glands, in this situation the clear difference in echogenicity is relevant, and then you can see hypoechoic. What is actually beyond the echogenicity of the thyroid? Why am I interested to say isoechoic and hypoechoic? Do I get any information for me as a clinician, not just to make a report with nice, I don't know, words on it? So echogenicity means if the echogenicity is lower, beyond it is either iodine deficiency disorder or autoimmune disease or active thyroiditis. So saying hypoechoic doesn't mean a clear positive diagnostic, but it's a clear indication of something wrong in thyroid. And then you go further in the evaluation, clinical, autoimmune, iodouria, iododenia, or send it to endocrinologist. So this is a clear hypoechoic image. Whenever I have isoechoic, meaning same echogenicity to the salivary submandibular glands, it means if you have a previous patient with some history with Graves' disease, the Graves' disease goes in direction cure of the disease, because normalization of the echogenicity is what it means. or is acute, subacute, or destruction type of thyroid disease, and we had hundreds of cases with destruction, subacute thyroiditis post-COVID. We had the COVID area, or we have a normal thyroid. And if it's a normal thyroid, it doesn't matter if it's 22 and not 20 milliliter. You have a healthy person in front of you who is maybe taller and more obese, and if you make a ratio to his body surface, he has a normal thyroid. What is hyperechoic? Hyperechoic means, like in the last picture, granulomatous infiltration or fibrotic form of thyroid autoimmune disease, meaning something wrong. So whenever it's less or few than normal echogenicity is a landmark in your head. Color Doppler. Color Doppler means normal functional tissue. So the higher the percentage of high vascularization means either hyperfunction or thyroid tissue trying to overwhelm a problem. What means normal Doppler? Normal Doppler means some spots in the thyroid. You see always the carotid artery as a landmark. No spots in the strap muscle. Whenever you have spots in the strap muscles, your gain is too high and you have to put it lower. What means increased vascularization means active tissue. When typical hyperproduction form of hyperthyroidism, and the most significant example is Graves' disease, but it also means thyroid tissue who is in a body with huge amounts of TSH trying to overwhelm the hypothyroidism. So not any vascularization means active Graves, but the message is whenever you see it, there is something wrong in the thyroid. So one of the two extreme, overt hyper or hypothyroidism, and even if you do not go beyond this, just refer it. And do not push in the direction, refer healthy patients to an endocrinologist. Whenever it's low, and low means almost no spot, it's an inactive thyroid tissue, meaning an acute aggression, the destruction, hyperthyroidism, which is not very rare, is not only the subacute one. It's thyroid atrophy, long-standing autoimmune disease, or post-radioactive iodine, or long severe fibrosis, and this is also something very wrong. It's not that you don't have the correct gain, it's really the thyroid is not working again at all. Disease activity, what one can see on ultrasound. So we have in Graves activity, relapse, direction, evolution to cure, autoimmune disease stages of subacute thyroiditis. So this is a typical increased volume, hypoechoic, this is the right lobe, this is vascularization, this is left lobe, sorry for the wrong animation. So right lobe increase in volume 20 milliliters, left lobe 18 together for 39, this is significant. Increased in volume thyroid with increased vascularization with low echogenicity, highly suggestive for thyroid disease. And if this comes together with low TSH or signs and symptoms suggestive for hyperthyroidism, the diagnostic of Graves is here. And because it's at the beginning of the disease and there is no nodule, you can refer it or you can start treating the disease. The second example, so the same increased in volume, hypoechoic. On your on your left screen, actually, there is, it starts to develop a nodule. This is an increased diffuse disease. This was a 14-year-old girl, July 2021, increased volume. I saw her again in 2002. In June, the same increased volume. The nodule was better to be seen. Again, the increased vascularization, and because there is no response and we had an increase in volume despite treatment, we know that it's a non-responding form of disease who developed nodule, so we should move in direction definite treatment or definite cure of the disease, and I won't go into details. This situation, normal echogenicity, normal volume, right lobe 6.6 mil, left lobe 2.4 mil, normal volume, normal vascularization. So this is either a healthy thyroid, but if the patient is a previous known Graves' disease under treatment, you have all the clues of the cure of the disease just by looking at ultrasound, normalization of volume, normalization of echogenicity, normalization of vascularization, and you can go into direction inactive disease and just follow up. Hypoechoic increased volume, left lobe, right lobe, entire volume 44 milliliters, so it's a clear thyroid disease. And of course, because if I have signs and symptoms of hypothyroidism or high TSH, I know this is a Hashimoto autoimmune disease and I can start treating it even if before referring to endocrinologist. Even such situations are possible, as I show you here. It's almost unbearable to see. It's like no thyroid at all, although there is a clue there. So it's a very, very small 0.7 mil right lobe, 0.2 mil left lobe, a very, very, very small thyroid. This is actually the end stage of the autoimmune thyroid disease that we expect. And take into consideration that autoimmune thyroid disease is present in up to 15% of female population, and it's something that we will see increasing because of iodine intake that we all have. And of course, in such an atrophic case, I'm expecting no activity at all. And what does it mean? I am expecting that this patient will need up to 100% supplemental treatment. So I have so many clues, but just performing ultrasound. I'm not saying fine tuning of the treatment, at least knowing the direction and knowing who to refer further. So low volume, hypogenicity, fibrotic lines, no vascularization is the atrophic end stage of autoimmune thyroid disease and refer to treatment. What else can we do? So this is a transversal scan, inhomogeneity. It seems to have in the middle on a nodule, and this is again the transverse longitudinal scale. So this on inhomogeneous pattern, it's like the old pavement in the center of Vienna or in Timișoara. So this is the typical image of subacute or destruction type of thyroiditis. And of course, there are some clinical clues that you might get. And here, one of the most important fields in which shear wave elastography will find its place, even in screening, these are always very, very stiff. And these stiff aggression type of thyroid diseases are highly suggestive beyond the clinical picture of destruction. So it's the aggression phase of autoimmune thyroid disease. And the same patient 1 month after treatment, the inhomogeneity of the thyroid is not as significant as before. Look, so again, the images here. So look how inhomogeneous they both were, and look 1 month after. So it's a huge change. And actually what is really, really nice is the decreasing of the increasing of inflammation, because it's the normalization of the disease. And it's a 2-minute type of evaluation, which is really, really excellent. And I know I can resume glucocorticoids in this patient. So there are so many clues in performing thyroid ultrasound. What about differential diagnostic? So we can make a differentiation of hyperthyroidism because the clinical picture is clear. It's the old-fashioned pulsatile Doppler. So whenever you measure on the inferior thyroid arteries, you make the pulsat Dopplers, and you see huge amounts of pressure. So this high activity, it means increased vascularization, re-emphasizing it's a hyperproduction type of hyperthyroidism. And whenever we have almost no activity, and it's not a subjective color Doppler, are values, this is highly suggestive for low vascularization, meaning destruction. And the number of cases that we see and the number of cases that are misdiagnosed is really, really significant. Not every hyperthyroidism is Graves. I have seen a lot of patients coming in with antithyroid medication, and if you deliver antithyroid medication in the destruction type of hyperthyroidism, you will, how should I say, with needed signs, somehow destroy the thyroid of your patient. So it's not so easy to think hyperthyroidism, just deliver medication. You can put a pathology type of diagnostic. Of course, this colloidocystic thyroid is highly suggestive for iodine deficiency disorder, and whenever we see hypoechogenicity, inhomogeneity with fibrosis, re-emphasizing the possible autoimmune background, which is increasing in percentage in the general population. Short talk about nodular goiter from the PoC-US point of view, because you will hear tomorrow a presentation about it. So ultrasound is the first-line diagnostic tool in nodular thyroid disease in order to make the characterization, to monitor the fine needle, and to observe the lymph node. Why do we do it? Because we have huge amounts of nodular goiter, and somehow by the end of our daily work, the vast majority of us will see nodular thyroid disease because it's present in more than 50% of the adult population. Where should we emphasize? Because we are not able, even if everybody will perform thyroid ultrasound, we won't be able to look and to see all the patients that actually are present in the general population. So we should emphasize or concentrate our efforts in direction. We have a suspicion from the clinical point of view of nodular goiter. We have a thyroid incidentaloma observed on different other imagistic evaluation like tomography, MRI, or PET-CT, or let's say carotid-artery Doppler, which is one also of the common incidentaloma lines. An anamnestic risk, and we will see in a few seconds what does it mean, or the clinical risk, because we should push our efforts in the needed or in the correct direction. What means anamnestic risk from the nodular point of view, thyroid nodular point of view? It's a personal history of cerebral or head and neck irradiation, usually for previous cancers. And you need between 5 to 10 years from the exposure to radiation till it's possible to develop the thyroid cancer and the second cancer. The present history of whole body irradiation, like in lymphoma with whole body irradiation before the stem cells transplantation, a positive family history of thyroid cancer, positive family history for other diseases that also involve thyroid cancer as part of the disease, or accidental exposure to ionizing radiation in early age. It's let's say, the trend of radiation bombs and iodine prevention in the entire Europe as a discussion. What means suggestive clinical signs? Not every goiter is suggestive for thyroid cancer. Not every goiter should be screened because we won't all of us have time to do this. Recurrent nerve paralysis, let's say acute onset, laterocervical lymph nodes, a tumoral block, hoarseness, or rapid growth. So if you have in front of you a patient saying he has one of these signs, be much more prone to look into his thyroid when just someone coming in saying I had an increase in my weight. Doesn't mean thyroid means too much food. Risk stratification. There are many risk stratification models used currently. Actually, all of them, as you will see, will take into consideration some structures. Not structures, some criteria. First of it is the shape, transversal scale, and longitudinal scan taller than wild. So meaning the vertical diameter is bigger than the horizontal diameter. The second one is the irregular borders, so highly suggestive for malignancy. Doesn't mean it's a 100% sensitivity, specificity, but it's highly suggestive. Inhomogeneity, regardless the type of inhomogeneity. Hypoechogenicity, and in this situation you make the comparison with the surrounding parenchymal thyroid tissue. And of course intranodular calcification. And of course lymph nodes, which are highly suggestive. What do we take into consideration? I just put the, let's say, the most used risk recommendation, European guideline from the American Thyroid Association guideline, European Thyroid Association, British one, Korean one, and also the European thyroids and the American thyroids, which are, let's say, the most recent risk stratification. And actually composition, meaning solid, echogenicity, shape, margins, and calcification are taken taken into consideration in all the modules. There are some differences then if they take into consideration Doppler, size, or lymph nodes. But actually, if you look only in that 5 criteria, meaning solid, shape, homogeneity, margins, and calcification present or not, you are able to have, let's say, a general information about the thyroid nodule. Why it's important? We don't make the risk assessment because we don't have what to do with our time. Because actually the risk assessment is selecting the thyroid nodules in order to know who and when to refer or how soon to perform fine needle biopsy. Because if we look, these are the major guidelines which we are currently active in the endocrine world. They do not overlap 100%. But the message is, if I have high-risk nodules and I have a nodule around 1 centimeter, I have to refer it to fine needle. If I have low-risk nodule, I can keep it, so to say, up it reach 2 centimeters when he need referral to fine needle. So from the PoCUS point of view, refer moderate and high risk, meaning at least one suspicion criteria in respect of shape, margins, echogenicity, homogeneity, and calcification, and just follow up the very low and low risk nodules, which have to be referred to fine needle to reconfirm benignity only when they reach up to 2.5 centimeters. And these are the vast majority of the nodules. What means very low? Typical cystic one with or without septum, but it could be only a full entirely fluid thing. It can be this one. This is not inhomogeneous. These are the luminescence sign of a very, how should I say, dense liquid, or only if this is working, the dispersion, not the case. Very low risk is the typical spongiform. It's a puff pastry-like nodule. It's oval, it's well-defined, clean margin. It's inhomogeneous because you have to imagine the puff pastry, but this it will be tissue, colloid, tissue, colloid, tissue, colloid. But it can be a trap because, for example, this one, which it seems to be with lines, is not a typical spongiform one. Again, on your left side, typical low risk fluid, posterior enhancement, inhomogeneous with some debris inside, but this one is not, even if you have the same whitish points. Typical the cat eye sign, so it's a luminescence with a posterior whitish, like the comet sign. It's like the tail of the comet here on the left side, and is not here, in which you have the same whitish, but this is calcification. So not every low risk is a real low risk. And this is also the puff pastry on your left side image, and this on the right side, even if it seems to be lines, is a typical sclerotype type of thyroid cancer. Again, low risk, the hyperechoic nodule, or the so-called giraffe sign nodule, in which it seems like the pattern in the giraffe skin. It's some fibrotic line. And not to forget the white knight, which is a typical hyperechoic regenerative nodule, which can be seen in autoimmune thyroid disease. So the message will be any risk criteria, again, re-emphasize it: solid, hyperechoic, margin, shape, and homogeneity, refer. If don't, you can keep it up to 2 centimeters when you have to re-emphasize benignity. So for the imagists, and we are more than imagists, we are mainly clinician, we should look behind anatomical integrity, morphology, vascular pattern, and just a nice description, because actually, for me as a clinician, anatomic integrity and morphology means diagnostic, positive diagnostic, differential diagnostic, disease evolution in respect of relapse or cure. It's a matter of disease activity and which treatment should I choose, because I have so many clues by just performing ultrasound. And of course, when I perform ultrasound, I'm not blind. I do see the patient. I do see his signs and symptoms. I not necessarily re-emphasize hyper or hypothyroidism by TSH or 33, 34 values. And restratification, important thing is, doesn't mean to have a nice description. Restratification situation means choosing between follow-up, fine needle, and of course in polynodular, compressive, and high-risk situation, even think about surgery. Thank you very much.
Here it's an honor for me. You have to know that I am a radiologist working in a private practice. I left the university several years ago, and I want to introduce you the concept of ductal echography. For you, the problem of the breast is your tumor, the breast carcinoma. But the big problem is where the carcinoma starts, how it grows, which tissue is involved in the carcinoma. So we have to understand all this information to be able to follow up the breast carcinoma development. You know, like doctors, that you have three tissues in the breast: the fatty tissue, the connective tissue, and the parenchyma, the epithelium. Unfortunately, you see that the rate of epithelium decrease when the number of carcinoma increase, and so it will be very difficult to detect the small abnormality here on the epithelial. The breast carcinoma is an epithelial disease. That's something that you will never see with ultrasound X-ray, but just for your culture, your information. You have here some ductal structure and here some lobules with a group of acini. And I don't know if the video is working. No. We will see the video later. And so that's important to know that you have normal epithelial group of cells and then hyperplasia and some with modification. The anatomy of the breast has been described by Ashley Cooper in England quite 2000 years ago, and he make injection in the duct and he tried to make a colorization of different globes. The best anatomic description has been done by our colleague Tavasoli, which is an American anatomopathologist, and she was in charge by the WHO organization of the classification of the tumor. And she described the anatomy of the lobe of the breast like petals around the nipple Each petal corresponds to the lobe. I told you that the carcinoma is an epithelial disease, but where is the epithelium located? In the lobe, of course, but in the lobe, in the terminoductor, here in the epithelial structure, duct and lobule, and more precisely, we will see that in the terminoductolobular unit. And you don't know what is that, but it's very important to understand. You have two types of technique to make examination of the breast. Conventional echography, orthogonal scanning of all the breasts, but you have no anatomic reference for this study. And most of the people do that. And so you have a good definition of the skin, the epithelial structure. But unfortunately, in echography, the fatty tissue has the same pattern that the epithelial structure, so that you are unable to detect here the small carcinoma because it looks like fatty tissue. So the Dr. Teboul in France, the first, many years ago, tried to develop that. Using the conventional echography, you detect a lesion. And to make a good analysis, classically the semiologic signs are speculation, angulation, microlobulation, thalers enlarged, duct extension, branching pattern, shadowing, calcification. That's great, but you have too many information. And where is the tumor? In which tissue? How should be his development? So we have poor information with the conventional echography. Just a question. My presentation is a concept, so I am not going to the semiologic details, but just try to answer to the question. Why classically, when you have a small tumor, taller than large, highly suspicious of carcinoma? If the diameter of the lesion is parallel to the skin, it should be benign in more than 90% of the cases. And in the next presentation, maybe we are going to answer. It's just a question. I perform with Dr. Teboul, the French radiologist, the ductal echography, the lobar approach. And we try to find the lobar anatomy of the breast and to make a radial scanning following the spherical axis of the duct. For that, we can have three types of probe. Linear probe, of course, but small, medium, or large. Unfortunately, the largest, the DREAM probe, is not available now on the market. So we have to work with 4 or 5 or 6 centimeter probe. And we try to use the longest probe as possible to follow the lobar anatomy. What is my concept when I am in front of my patient? I put the probe on the breast, and each lobe for me is an independent unit, completely independent. And in the lobe, you have some ductal structure and some lobules. Each lobe is independent. And you have a specific zone where the carcinoma and the pathology will start. It's at the crossing section between the Cooper ligament axis and the ductal axis. And there you have a specific terminoductolobular unit where the carcinoma will start. So now you have the radial scanning and the description of the lobar anatomy. We permanently put the nipple at the upper lower part of the breast because each lobe is the same. So you have here the nipple, the areola, the skin. Under you have the chest wall. Here you have an hyperechogenic structure, which is the lobe itself. In the lobe you have some ductal structure and some lobular structure. And here I will develop for you the presence of the Cooper ligaments. Do you know in the breast imaging technique, one technique which is so precise and so similar than to the histologic scanning? Professor Tibor taught an anatomopathology, make for me this wonderful histologic scanning. You have the nipple, the areola, the skin, the chest wall. Here you have the lobe itself. At the upper part of the lobe, you have the Cooper ligament linked to the fascia superficialis, and here you have the reticula cutis. At the inferior part of the lobe, you have the inferior Cooper ligament linked to the fascia inferior. And if you look to the lobe here, it's exactly the same pattern that the histologic, and you have the nipple, the areola, the skin. Look at the Cooper ligaments, superior and inferior. Only the radial technique, ductal echography, can show you precise anatomy of the breast. And then you see best. You see a huge difference between conventional echography and the fibroglandular block and the ductal echography with the analysis of the anatomy and the Cooper ligaments. You have no problem, only ductal echography show you such nice information. Now, something very important. Professor Tibor, who made this fantastic histologic section, developed the thick lobe theory. What does mean? That from several colleagues, and at the true beginning, here in 1969, when the American people put the feet on the moon, he described the first characteristic of the carcinoma, and he said that the disease is not a focal disease, but it's a disease we affect diffusely the epithelium. But nobody in breast imaging or the practitioner can understand what that means in the reality. Then Michel Teboul, in his first book, described the notion of potential here, diffuse disease of the epithelium. And then in 2005, Todd Tibor developed the thick lobe theory. Have a look to that. You have here the initial duct with the progenitor cells and the epithelial cells. We don't know exactly why, but you have some mutation of the progenitor cells here, and then you will have the progeny of these cells which are affected. They are not cells of cancer. They just have cells with mutation, which they will be more sensitive to oncologic stimuli than the normal cells. And if you look here, when the pathology starts early time, you have only small part of the duct and the lobule which are affected, and then development, larger development, and the time of the modification is going to create a part of a lobe or total lobe affected by this modification. And the conclusion of Todd Tibor that the breast cancer is not a tumor, it's not a lump, but it's a lifelong, progressive, multifocal, heterogeneous, and extensive disease, not a tumor, a disease, involving a whole lobe breast, and I should say lobes plural, because you will see that you should have several lobes affected by this genetic modification. And the most important publication of Todd Tibor is this one. He makes an analysis of 900 tumors, proven carcinoma, and he select the rate of multifocal, invasive, limited, or unifocal. And if you have a look here, you see that at the in situ carcinoma, you have 20% of unifocal. 20% of unifocal, that means 80% of multifocal. For the minimal breast cancer, 15 millimeters, you have 30% of unifocal. And for bigger carcinoma, you are around 30% of unifocality. The breast carcinoma is not a tumor, it's a disease with multifocality or multicentricity. That means that when you perform your breast examination with ultrasound, maybe you have modification well detected by ultrasound, but also here you have one lesion at the extremity of the lobe and 9 centimeters here, a second one, and here you have 1, 2, 3. So you should be able to detect the anatomy of the breast, to follow the duct axis, to detect the crossing section between the Cooper ligament, and to see if you have any atypical abnormality. Here on the X-ray, you have an abnormality. It's not the carcinoma. X-ray is not able to detect carcinoma. It detects the stroma fibrotic reaction around the tumor. But you know that the carcinoma, it's an epithelial disease, and the epithelium is located in the duct. So you have here the lesion, and here the nipple. Have you any information of the duct between the nipple here and the tumor there? No, because at the early stage, the epithelial structure are not detected by ultrasound. If you look to ultrasound now, you have here the tumor corresponding to this one, left breast at 2.5 o'clock. But if you go to the nipple, follow the nipple, you have here 1, 2, 3 localizations, and here you have only one. That means that if you don't perform at the early stage a good examination, you are going to miss the multifocality. And so when you make your report, you have to make a precise mapping and to say to the surgeon, at 10 o'clock, you have 2 lesions, and so on. You see, you make a really precise mapping of the atypia. You cannot assert at this time that it's a carcinoma, but it's atypic, warning signs. So you give to the patient and the surgeon to make the best treatment for the best analysis of the disease. And then here, following the duct axis with the radial scanning, the nipple, the areola, you have a lobe, and here at the crossing section with the Cooper ligament, you have 1, 2, 3 lesions. And here you see that this lesion is taller than large. Why? We discuss that later. And then you understand that echography is able to detect small lesions. But you know that the pattern of the suspicious lesion is the same that the fatty tissue. But using elastography, you see perfectly here the lesion itself, but also here the affected duct here, which is not detected there. So elastography become a necessary complementary technique for the diagnosis, and today I cannot imagine that I do not use elastography for my diagnosis. And I can use all the Sherway technique or the strain technique to I have a chance to have these two techniques and to compare the result, and it's really a fantastic tool to use the two techniques to make a good diagnosis. And with elastography, you can insert that the lesion is not a 4, but a stage 5, so you assert the malignancy. So the conclusion. You are, all of you, going to use the conventional echography because you have not the long probe, because you are at the beginning of the starting. So you make conventional orthogonal scanning. But as soon as you find something, please go to the radial analysis and try to follow the lobe anatomy, the ductal axis, and the small modification at an early stage before the signs of X-ray. The carcinoma is not a tumor, it's a disease, multifocal or multicentric. And as soon as you detect one abnormality in the breast, please try to find the others. We are not able to detect all the small foci, and every day I make mistake because I missed some of them, but I try to be my best to do not miss too many lesions. And of course, echography is not the solution of the diagnosis. You need to use mammography, MRI, echography, Doppler, elastography. All these techniques are complementary techniques, but believe me that the ultrasound is the more precise technique to make a good anatomic analysis. And if you understand what you are doing, you will progress faster and it will be more fascinating for you. Thank you for your attention.
Good afternoon. My name is Yuda Zicherman, and I would like to thank to the organizers of this conference for putting together such interesting sessions, as well for inviting us to participate. So as you well know, ultrasound is one of the most useful evaluation tools around. But in fact, it is underutilized, especially in the point of care in hospitals and in the community and primary care physicians. So, how we make ultrasound available for emergency room and primary care clinicians, especially in cases when the clinician is not a trained echosonographer. Number one, by making sure that any doctor, even one without proficiencies in using ultrasound, can get optimal readings. And number two, by making it possible to use those readings to make meaningful decisions to the next best step for the patient. So, by integrating artificial intelligence into the echo diagnosis procedure, a handheld ultrasound device, we believe, that costs a few thousand of euros, has the potential to become a leading diagnosis tool for community clinicians. Last year, we presented our methodologies for developing the technology for primary cardiology care. Let us see now, a year later, how we do it in real time on humans. So, we pre-recorded the typical examination of a patient in a clinic. You will be able to see exactly how the system evaluates the operator's performance toward optimal acoustic window, both position and quality. We will also see how we derive qualitative and quantitative outcomes of 10 different parameters readings that can be used to determine the next best step with the patient. Also, you will be able to see how much time a typical procedure takes from the beginning of the echo process until its completion. We call it 2 positions and 4 different views in under 5 minutes. So the first case concerns a 40-year-old male who scheduled a routine visit to his family physician clinic. As a part of this routine, an initial cardiac assessment is made due to the visitor's family history. An AI-powered handheld probe is used to search for outcomes in 4 echo views. The first is subcostal 4-chamber. The system indicates with a different set of colors how optimal the view reached by the physician is. An optimal view is obtained with a few steps. Then the system automatically calculates the RV over LV ratio and whether pericardial effusion is visible or not. The results are presented immediately after. You can see in our case that RV over LV equals 2/3, which is normal. Then the system guides the doctor to rotate the probe and reach the next view, subcostal IVC. Once an optimal view is reached, the technology calculates IVC size, whether dilated or not, and the collapse rate. You can see that the IVC size in our case is normal, and IVC collapse rate is more than 50%, which is normal too. Both outcomes are shown in the new results together with the previous ones obtained in the subcostal 4-chamber view. So, as the examination continues, the clinician is asked to move the probe to a second acoustic view to get the apical 4-chamber view. The same methodology is used to assist the user to get the right view at the right new spot. As before, the results are presented. Now it includes left ventricular volumes, meaning diastolic volumes and systolic volumes, stroke volume, ejection fraction, cardiac output, and heart rate without the need to connect to an ECG. You can see that the end diastolic volume is 103 milliliters and end systolic volume is 42 milliliters. Stroke volume is calculated to be 61 milliliters. Ejection fraction is calculated to be 59%. Cardiac output is 1.4 liters per minute and heart rate is 72 beats per minute. These outcomes are added to the previous results from the subcostal view, 4-chamber and IVC. Finally, using the same methodology, the technology guides the user to reach the apical 2-chamber. The results are presented in a final report. You can see that EDV, ESV, and SV have been slightly changed. The reason is that final results are based on the biplane Simpson method rather than just the monoplane Simpson as seen here. As presented, the technology instantaneously and automatically presents the cardiac parameters that are believed to be relevant to the ER and the primary care clinician. In this case, normal results are recorded and the clinician can make his decision accordingly. The whole procedure takes about 5 minutes. So we would like to ask you, are these results sufficient? Do you think that the methodology is intuitive enough to help you in your practice? And we will welcome your feedback. The second case concerns a 50-year-old man who complained of a recent onset of shortness of breath and fatigue. Upon examination using a stethoscope, the heart sounds were normal. Other parameters were such: blood pressure 103/68 millimeters hydrogen, heart rate 100 beats per minute, respiratory rate 14 breaths per minute, and weight is 83 kilograms. We follow the same procedure and begin with subcostal 4-chamber view. With this specific patient, you can see that the technology detected right ventricle enlargement compared to the left. Ventricle and pericardial effusion are not visible in this view. Might be due to the fact that apex of the heart is not fully visible in this view. You can see that view equality indication is moderate, orange color, which reflects the missing sector of the apex. A moderate view quality is calculated by the AI, but may have limitation that the next view may overcome. In case only a poor quality view is reached, the system can be overridden by the operator and move on to the next view. As before, the system asked the user to move to the subcostal IVC view. Subcostal IVC view shows dilated IVC and mild IVC collapse rate below 50%, which corresponds to the enlarged right ventricle that was detected in the subcostal 4-chamber view. The revised results page is presented. Now continue to the apical 4-chamber view. You can see that the right ventricle is enlarged compared to the left ventricle as detected in the subcostal 4-chamber view. But, moreover, new information is detected by the system due to the complete green color view that includes the whole apex in the apical 4-chamber view. A mild pericardial effusion is visible around the right ventricle and apex. This is indicated on the results page in addition to the left ventricle volume calculation, which means the ejection fraction, cardiac output, and the volumes. Finally, using the same methodology, the system guides the user to reach apical 2-chamber. The view deviated from the expected picture. And therefore, the AI does not designate the view as green. Though it is an issue that our AI application should do in the future, the difficulty to find a green view in this case also indicates clinical findings. The shape of the left ventricle is unusual in this case, due to the right ventricle enlargement. So we have our deficiency, but it's derived from clinical reason. You can view the final results page that was obtained again in less than 5 minutes. So, the outcomes are: the right ventricle is severely enlarged, the IVC is mildly dilated, and does not collapse. The EF is normal, The findings justify referring the patient to a more extensive cardiology examination, such as full echo exam. To sum up, from our perspective, mission accomplished. And now we eagerly await your feedback. We will have a Q&A session at the end of our presentation. I would like now to share with you a few words from TRISO's founder, Dr. Binyamin Shadi, who is a visionary practicing cardiologist.
Echocardiogram is a very useful tool. It's used all the time to evaluate cardiac function, and I had ideas how to get the data from it quantitatively, which is not readily available, or very more routine than an EKG, I think. Stethoscope is very quick and easy. This involves a little gel on the chest. But if you immediately get results and you need to see what what's the cardiac output, what's the LV wall thickness, the data that you get, the results you get, are the value is so great that it could be that it could become a routine tool that you would do it on every patient.
A quick spontaneous interview with Dr. Poliak, a radiologist and medical executive who acts as a company clinical advisor. Dr. Gabi Polak, you are a radiologist and senior manager in a big hospital, in a healthcare system, HMO, in emergency care services. What made you so enthusiastic in Point of Care Ultrasound that you joined this project?
Well, I'd say the major thing that really made me enthusiastic is truly the major impact that I can see on the three players in the system, on the patient, the physician, and the health system itself. Whereas today the process is cumbersome. The patient usually gets sent from the primary care physician to a specialist who could be a radiologist, a cardiologist, etc., at a separate location, at a different time, which is quite a cumbersome process. Here what we've done, we've managed to shorten the diagnostic process in a major way, which really results in a quick, an immediate, instant, and in real-time diagnosis. So we've created a bedside diagnosis, a new and sophisticated tool that really enables the primary care physician to come to a fast diagnosis on spot in real time. That is a major difference for all these three players. The fact that the primary care physician can come to a diagnosis immediately on the spot without sending the patient to a specialist has a major impact. This definitely is the new stethoscope, and the newer generations will be medically trained using this device, and I would say that in 5 to 10 years' time there will be no question at all. This will be the gold standard and the common practice.
Now I would like to show you a short interview that we recorded with Dr. Amir Shachar, who is Director of Emergency Department in Laniada Hospital. Amir will be conducting a clinical trial next month on 50 patients using the TRISO system and compare the results to those of trained sonographers.
In the nearby future, the patient will have quite a new and fantastic way of his examination in the emergency department. Guided echocardiography will be primary and essential step in evaluating the patient with chest pain in the emergency department, and will provide both the nurse and physician with medical information that will lead him to the diagnosis in another new and more efficient way of evaluating him in the emergency department.
As promised, we will move to the Q&A session for the time remaining. We will do it with our clinicians, Dr. Gabi Polak, who is a senior medical executive, and Michal Binenbaum. Good afternoon, my name is Yehuda Zicherman, and I would like to thank to the organizers of this conference
by one of the most